Welcome to Health is Number One podcast. I'm your host, family physician, Dr. Craig Wax. We're talking about what's going on today, which is COVID-19 or coronavirus, and the fact that it not only causes a pulmonary or lung problem like pneumonia does, it's a full body illness like pneumonia is, except there's some extra special things about it, and special in a bad way, unfortunately. It causes inflammation. And here to talk about it is the godfather of inflammation, Dr. Richard Fleming. Dr. Fleming, can you tell us a little bit about your background and experience?
Well, I am originally a physicist, nuclear cardiologist, which makes me somebody dumb enough to take more training. And I've spent several decades looking at different theories about what causes diseases like heart disease and cancer and infections like COVID-19, and I've spent some of that time investigating the tests that we use to try to figure out and diagnose what's going on.
Wow, well, that's tremendous. And where is your current practice?
I'm out here in Los Angeles, although I've been all over the country. I trained as a cardiologist in Houston.
A brief amount of your knowledge of inflammation, which unfortunately we don't have 3 days for.
Inflammation, it turns out, is the body's reaction to something coming into it and having an effect that shouldn't be there. So it doesn't matter whether we're talking about heart disease or cancer or these infections. When this virus comes into people's bodies, one of the ways that you respond to it to try to bring it under control is what's called our immune system. And those specialized cells and messengers go about the job of finding the virus and attacking it and trying to get rid of it. Now, too little response and the virus continues to run amok and have its way. Too much of a response, and it not only kills off the virus, but it also can help kill off you. Much like the example I like to use is rheumatic heart disease, where people come down with strep throat and you make antibodies to the strep. Those same antibodies recognize the valves on your heart. They don't intentionally want to damage your heart, but they do. So many people that are dying from COVID-19 infections are doing so because they also have heart disease and cancer and strokes and those types of illnesses that are already having an immune inflammatory response. So all COVID-19 is doing is gearing that up a little bit more. And we've shown that if you treat that infection and control that inflammation, you not only get rid of the infection, but you don't have the consequences of people dying from it. So it's not the virus that's killing people, it's the reaction to the virus.
I see. So the virus gets into our cells and then it inserts its genetic information into our cells, and our cells, tend to take over making more virus, which is a huge part of the problem. And the response to all of that is inflammation. Is what you're talking about. And it seems that people that have inflammatory issues going on already, we tend to think about diabetes and heart disease and blood vessel disease, strokes, and high blood pressure, high cholesterol, and everything that changes the blood's natural parameters with the immune system. Even obesity, we tend to think of smoking as quite inflammatory, but we're finding that just obesity or being overweight is an inflammatory problem.
Exactly. You need to be asking very fundamental questions with how can we stop the virus? How can we stop it from reproducing itself? How can we stop it from producing inflammatory response? What do we need to do to control that inflammatory response so it doesn't gear up other areas of the body that have similar problems, like your heart and your brain and kidneys and everything else that's resulting in blood clots and strokes and heart attacks and people dying. And many of the drugs that we're looking at right now, one of the problems is that all the studies that you're hearing about in the news are not actually measuring what this virus and this inflammation are doing. And that's where we have the only test that's able to actually measure that. And that's what we need to be doing, is measuring that response and then using the different medicines to treat people and then measure whether those treatments are working. We've spent months disconnected from each other and disconnected from the patient, kind of floundering in the water, so to speak, and not making much progress. But the truth of the matter is that we have many medications which should work. There's a reason for them to work that are being dismissed without any information to dismiss them, and other drugs that we're talking about being useful that we have very little information to actually prove that they do work. And one of those examples is hydroxychloroquine. This is a medication that by all means should work because, and I know I'll probably bore people, but it inhibits toll receptors on the cells, and toll receptors, when activated, cause an inflammatory response. So hydroxychloroquine blocks or inhibits the toll receptors. It's also an ionophore, which means it opens up little passages from the outside to the inside of the cell for something called zinc to enter into the cell. Now, the University of Oklahoma has actually done a tremendous amount of research on this in the past, and it turns out that you don't need a lot of zinc outside the cell to get in. It's the opening up of the ionophore that allows the zinc to come in, and the zinc then inhibits the production of the virus. You inhibit that, you inhibit the inflammatory response.
Okay, so when we talk about measuring inflammation, when I was trained way back when in the 90s, we talked about eosinophilic sedimentation rate, or ESR, as a measure of inflammation. Right. And then later, in the 2000s, we started to talk about CRP, C-reactive protein, and then what they called high sensitivity CRP, right, to look for cardiovascular disease. Can you tell us briefly about those inflammatory markers and new ones?
Right. Well, the important thing to recognize about every one of those blood tests, it doesn't tell you where, and it doesn't tell you what the inflammation is. So the problem with using peripheral blood tests is that they say something's going on somewhere, but they don't identify the problem. So you could have something else going on that causes those to be elevated. It doesn't mean it's the virus causing it.
So may I interject here just an analogy that seems to work for patients? I tell them a fever is kind of the same thing. It's like your check engine light. It tells you something is going on somewhere, but it doesn't tell you what and where.
Exactly. And what we need to be doing is using FMTVDM to actually measure what's going on in the lungs. And this is not a subjective test. This is objective. It measures. It actually defines what's going on at the tissue level. And that's what we need to know. Now, the key thing to being able to measure that is that means that within 72 hours of beginning a treatment, we can then measure the effect of that treatment and know for a fact whether the treatment helped, you get worse, or everything is just kind of status quo and hasn't changed. And if it's getting better, that means stay on the treatment. If it's getting worse, it means you better change treatment. And obviously, if there's no change, you might want to think about it. So a brief explanation of FMTVDM. It first begins by calibrating the cameras so that a camera in New Jersey and a camera in Los Angeles and a camera in Wuhan will give the same results. It's a nuclear imaging camera, so it can be any of them. So you can have a planar camera that goes to the patient's bedside if they're so ill or they're on a ventilator, or you can bring them down and you can use a SPECT camera, or you can use a PET camera. That's a positron camera. And I have to go through and train the nuclear technologists, the people running the cameras, how to actually do these studies, because this approach, even though we've been using it, it's developed over 2 decades now, measures what's going on. It's a complete paradigm shift in medicine because it has taken us from the field of looking at something to seeing if we think there's a problem, to actually measuring it and saying it doesn't matter what the human thinks. This is, by the way, this is what real AI, artificial intelligence, is. So that the real benefit is that since it is now calibrated, I can take a patient, and what I do is we give them what I call an enhancing agent. This is an agent that shifts the blood flow to the areas of greatest blood flow and greatest metabolic activity. So as you, I think, understand where the virus is at and where the body is coming in to attack the virus, that is a very metabolically active site. It's not just an air sac in the lungs exchanging oxygen and carbon dioxide. There's living tissue now, a virus going in and affecting things, and your immune system coming in to attack it, which is very metabolically active. So the enhancing agent shifts the blood flow to those areas preferentially over areas without that going on. And then we give you an isotope, which is a radioactive compound that follows the bloodstream and gets taken up by the cells of the body. So the more metabolically active and the more blood flow, once we enhance it, we will shift it to that. And then the camera is able to go around the patient or just be stationed in one position, doesn't matter, and collect that information. And that count says how much activity is going on in that area of the tissue. TVDM is a test that you're going to do something about with these treatments. You're going to do the test, you're going to give a treatment, you're going to wait 3 days for the treatment to have an effect, and you're going to repeat that test and say, did that treatment work? And you're going to be able to measure it. And then you're going to be able to come up with numbers. And if you think about this, 72 hours, it should be possible to take this and implement this everywhere in the country that these studies are occurring and in the world. If it takes 72 hours to find out a result, I would argue that within 2 weeks or 3 weeks, let's play devil's advocate, there will be enough people that will have been entered on these different treatment arms that we will be able to measure outcome data. And in 2 to 3 weeks, we can then go, wow, this drug worked this percentage of the time, that drug worked this percentage of the time, and by the way, they got off the ventilator in these number of days, they got out of the hospital in this number of days, and this percentage of them lived. Right, well, the initials again are FMTVDM. Has a long name. It's called the Fleming Method for Tissue and Vascular Differentiation Metabolism using same-state single or sequential quantification comparisons. Hence, FMTVDM. It's a patented test which I developed. It took about 2 decades to do. It is available with license, which comes from me. And for your viewers, I have agreed that anybody doing testing on COVID-19 patients who's interested in investigating which drugs are working and which ones don't, I will make this test available for free. You know, right now a lot of people say, gosh, why aren't all the MIs coming into the emergency room? Why is there so much fewer? I'm convinced.
Why are the heart attacks and strokes staying home and not appearing at the ER?
Right, and I would argue that they are appearing at the ER. They're appearing at the ER with a COVID-19 infection, and that infection is making them worse, and they are dying, but it's being missed because everybody's focusing on the virus and not the reaction to the virus. This is really the forest for the trees phenomenon. And to simply say that somebody died from COVID-19 because they have COVID-19 is missing the point. They may be dying with COVID-19, but that COVID-19 is, I'm convinced, producing an inflammatory response. People are now beginning to admit it, but they're not connecting the final dot, which is, wait a minute, if it's really causing this inflammatory response in the body, and people's heart disease and cancers and high blood pressure and strokes are caused by this inflammatory response and blood clotting that goes along with that inflammatory response, this is why they're dying. And what we're seeing are the people that are very old, that already have all these illnesses and inflammatory responses, people that are younger with these other diseases, which are inflammatory responses.
Dr. Fleming, if I might ask, we talked about inflammation. we tend to think of things in medicine as acute and chronic, whereas acute is short term or less than 6 months, and chronic is longer than 6 months, like, for instance, diabetes, high blood pressure, or obesity, versus something acute, which might be a cold or a seasonal allergy attack or something, or a trauma that's just temporary. Can you tell us a little bit about which puts a person at risk, in your opinion, with regard to COVID-19 coronavirus, acute or chronic inflammation, or both?
That's a good question, and I think it's both, depending upon who you're looking at. I think when we're looking at the older individuals and people that have had coronary artery disease and those types of problems for a long period of time, that those chronic inflammatory diseases are simply made worse. Even though we developed the theory or I developed the theory on inflammation and heart disease back in 1995 and published in a textbook of cardiology in 1999, we went ahead and investigated people who had some bacterial infections that were making their heart disease worse. We noticed that they had some blood tests that went up, indicating an infection and indicating inflammation. But we also noticed that their nuclear images of their heart showed progression of disease from where they had started. These people that had bacterial infections, something I called bacterially aggravated atherosclerosis, the thymus gland became more pronounced from the heart disease, and the heart disease got worse during these infections. When we treated these infections, which by the way included things like Zithromax and Biaxin for these infections, the bacterial infection went away. The thymus gland no longer was activated. The white blood cell count came down, and the heart disease improved and went back towards its current level of disease. It didn't reverse all the heart disease because there were other things going on. And my argument again is that it's not so much the infection as how we're responding to it. And you have to do more than just identifying the cause. You have to actually treat the consequences of that cause. And what we're not focusing on is treating those problems.
Right. So, Dr. Fleming, what I'm hearing that needs to happen is we need to study more about the virus and what it does to the body to increase the amount of inflammation that goes on, because it's important to differentiate, and I believe you'd agree, that there are people that die with illnesses and COVID-19 coronavirus, and there are people that die from coronavirus COVID-19, correct? And they're two different basic subsets of people.
Oh, absolutely. And let's establish one thing. When you get a virus, that virus is with you for life. You will never be rid of it. This is true of any virus or infection that you get.
So to summarize, we need to start measuring inflammation, and you've developed a test for that. And despite the patent and the universal world license to that, you're willing to share that with the world under, certain protective circumstances which seem reasonable. If someone wants to contact you about that, a scientist, a regional laboratory pathologist, what would be a good way for them to do that briefly?
The best way is just simply to email me, and they can do that at drrichardmfleming@gmail.com.
If you were to summarize what the differences are in COVID-19 coronavirus and what it does for inflammation, and the differences between inflammation of different disease states, and the fact that they seem exponential when you have inflammation from one disease state and then like a chronic disease state like obesity, hypertension, or diabetes, and then you have an acute infectious agent which sets the body's mechanisms off quite a bit, then what are the differences in brief summary form?
Well, I think the best way to think about this is that you already have these other inflammatory diseases going on, and they are little fires that are going on throughout the body all the time. You bring in COVID-19 and it's a match. Now, if you don't have gasoline fires going on elsewhere in the body, that match doesn't do anything to it. You now throw that match into people who have these other inflammatory fires going on, and you just activate them.
Got it. So if the gas is on, you'll have fire, and if the gas is off, the match just burns out.
That's right. That's right. And your immune system comes in and puts it out like water on a fire. The reality is what they need is the ability to measure what's going on.
Thank you very much, Dr. Fleming. Thanks for taking time with us today and explaining the difference between patients that die with coronavirus COVID-19 and die from coronavirus COVID-19. Big difference. And the difference has to do with inflammation. And inflammation is the thing that not only causes the death of individuals, it can shorten the lifespan and decrease what life is worth and the ability to express yourself during life. Thank you again for being with us. We look forward to seeing you again next time with another amazing topic and another world-class professional right here on healthisnumber1.com. Thank you.
Thank you.
And here's the Dr. Wax fist bump. For this and more information, you can go to healthisnumber1.com. You can also Twitter with us at the @ Dr. Craig Wax, DrCraigWax, and the same at Instagram and on Facebook as well.